Much. Thank you for the invitation. So I'm going to repeat many things that have been said today. So you all know that there are 14 muscles that move and stabilize the shoulder, and I stress this word of stabilize because I think it's very important to understand that they don't only move the shoulder, but they are really stabilizers of the joint because the shoulder is so special. It's an unconstrained joint, and so you need two force couples, one vertical between the deltoid and the rotator cuff, and one horizontal between the anterior cuff with the subscapularis and the posterior cuff with the infraspinatus and teres minor. And in order for the shoulder to elevate or to do abduction, so a movement of rotation, you need to have a fixed center of rotation. And so the entire rotator cuff has to pull the head to compress the head against the glenoid so the center of rotation can be fixed for the deltoid to be able to act as a rotator. And so here you have an unconstrained joint, so a shoulder, and if you have only a deltoid and no rotator cuff, well, what's going to happen? The deltoid is going to contract and is going to pull the head superiorly, and there's going to be translation and no rotation. That's different in the hip, where you have a constrained joint because you have a different shape, and so the bone acts as a force couple with the gluteus medius, and so you have a fixed center of rotation, and so you have rotation. And this is what happens in certain shoulders. And this lady, she has acetabulisation of the acromion. And so her joint acts like a hip and she has full active range of motion, limited pain because she has a fixed center of rotation. And this is how she can now rotate around the center of rotation. When you don't have this acetabulisation, so in a regular shoulder, you need to have a deltoid and a functional rotator cuff. With this functional rotator cuff, you're going to have contraction of the cuff, a fixed center of rotation, and then you're going to be able to elevate or abduct the humerus, and so have a rotational movement around the center of rotation. When this is not possible anymore, well, you need to modify the anatomy of the shoulder, and this has been the idea of Paul Gramont, as you all know, with three main principles. The first one is to medialize the center of rotation, as you can see here. By medializing the center of rotation, you increase the momentum of the deltoid. By doing that, you don't increase the strength of the deltoid, but you decrease the strength necessary by the deltoid to execute the same movement. Then you distalize the humerus. As you can see, the greater tuberosity is further away from the acromion on the right picture. And by doing that, you retension the deltoid. And so this allows an easier contraction of the deltoid. And one of the most important things is that you transform the joint from an unconstrained joint to a semi-constrained joint. And by doing that, you remove all the parasite translation movements, and as soon as you have a strength that is applied to the joint, when the deltoid contracts, all the strength transforms into rotation and no more translation. Initially, this great invention was made for cuff tear arthropathy because before that, the only solution that we had was a hemi, and Paul Gramont proposed to treat these patients with a reverse shoulder arthroplasty. But then, progressively, in around 2005, 2007, some surgeons proposed to use this arthroplasty in cases where there was no arthritis, which was completely crazy at the time. But they proposed to use that when non-arthroplasty options have failed or were likely to fail. And this was proven to provide reliable pain relief, return of shoulder function in patients with massive rotator cuff tear without arthritis. So the whole goal of the presentation today for reverse shoulder arthroplasty for irreparable rotator cuff tear without arthritis is to determine which are these patients where non-arthroplasty options have low likelihood of success. So first we have to go back to the definition of an irreparable rotator cuff tear, but I'm not going to go through that. You all know these different classifications. But then when you have an irreparable rotator cuff tear, we know from Philippe Collin and Gilles Valche that depending on the remaining muscles, on the muscle balance that the patient has managed to achieve, and that whether there has been a history of repair, of surgery or not, the pattern, the clinical pattern is going to be different. And so we have different patterns. This has been very well described by Pascal Boileau. You can have a functional shoulder, which means that the shoulder moves, but it is limited by pain. And so you can see the patient, you can think that the patient is limited under 90 degrees sometimes, but it is only pain. And if you help the patient, then you're not going to have any elevation lag sign. And so in these patients, you can have all these situations. The most frequent are type A, C, and D. I added the type 0, which is not in the classification from Collin, but irreparable supraspinatus can also lead to a functional shoulder limited by pain. And then the type B, C, and E, we know from this study that in 20%, 55%, and 67% of these cases, the patients are not pseudoparalytic, they have a functional shoulder and are limited by pain. Then you have the non-functional shoulder, and the non-functional shoulder can be in the vertical plane, type B, C, or E, or in the horizontal plane when you have the entire subscapularis or the entire posterior cuff that is disrupted. And you can also have a combination of both planes with the same rotator cuff patterns. So first, you have to keep in mind that it is always a chronic situation. So you're not losing time by waiting. So there is no rush. You should always begin with a non-operative treatment for these patients with injection, physiotherapy, and we've seen a very good example with Giuseppe just before of a patient that recovered full active range of motion, although he was pseudoparalytic, because a substantial number of these patients will improve, and there is no indication for surgery until there is full passive range of motion in these patients. And we all have examples of patients like this who have massive rotator cuff tears, irreparable tears, and they have a very good range of motion, and they don't need surgery at all. So let's go to the functional shoulder. The functional shoulder, we've seen this video previously today from Philippe's talk. It's a patient that has limited motion by pain. This is what Pascal Boileau calls painful limitation of anterior elevation. So active elevation can be less than 90 degrees, and some people say that this is pseudoparalysis, but it is because of pain. And you see very clearly in this patient, if you help her or if she helps herself, she can maintain the arm above 90 degrees, so she has no elevation lag sign. When we talk about loss of horizontal balance, it's very clear with the external rotation lag sign and the internal rotation lag sign, but for the vertical plane, the elevation lag sign is a very easy sign to understand. You put the arm of the patient above 90 degrees. If the patient holds, well, it's not pseudoparalysis. If he holds, if he does not hold, it is pseudoparalysis. So for these cases, you can have isolated irreparable supraspinatus only. And we know that the biceps tenotomy works very well for these patients. We know also that the SCR with the biceps can work very well for these patients. But the problem is that often these patients, they come to your office and they already had a surgical repair that failed. And so what can you do? You cannot use the biceps anymore because often it has been cut already. So you can go for a partial repair. It has been shown that it works. You can go for a graft, a patch, an SCR. You can use the balloon, or you can use a medialized repair. The problem is when the infraspinatus is involved, because when the infraspinatus is involved, we have seen very clearly from JP Warner's team that the SCR gives bad results as soon as the infraspinatus has over grade 3 or 4 fatty infiltration. So we believe that this is an indication for tendon transfers, and whether you go for latissimus dorsi or lower trapezius, I don't think it has any importance. Both tendon transfers have shown that they work. You have to use the tendon transfer that you're used to, that you are more comfortable with, but both provide similar results. Then you can have irreparable supraspinatus that extends anteriorly to the upper subscapularis. So there, the biceps tenotomy does not work anymore. We know that when the subscap is involved, the biceps tenotomy only does not work as well. And so it's again an indication for tendon transfers, and we've seen that previously with the pec minor, the pec major, or the latissimus dorsi. Similarly, there's good track record with the 3 tendon transfers in the literature. So you choose the one with which you're more comfortable. They all seem to work approximately the same. Then there is a case that starts to become complicated. It's the type C. You know that the type C in a large amount of patients leads to pseudoparalysis, but in 55% of them, they are not pseudoparalytic. So they have a functional shoulder like this guy, very painful. And you can see that the imaging is not very encouraging. He has had a previous Latarjet a long time ago, and he has no supra, no upper subscap, no infraspinatus, but a good teres minor, and an okay inferior subscap. And so either you look for which function is the most altered clinically, where is his complaint the most, and this is what we did for him. We thought that what was bothering him the most was internal rotation, so we went for isolated latissimus dorsi transfer, And of course, it's not perfect, but he was improved, and he's a manual worker, and he's back to work. So he has no great strength, and you can see the internal rotation is not perfect at all, but he's improved, and it's another way than to go straight for an arthroplasty in these patients. Then there's the technique described by Bassem, the parachute technique that I myself have never performed, but you have a loss of muscle in the front, a loss of muscle in the back, so it's logical to bring a tendon transfer in the front and another one in the back, so either lat dorsi to the front, teres major to the back, lat dorsi to the front, or lower trap to the back. That's a possibility. The problem is that in some cases, it is a theoretical indication for tendon transfer, but the tendon transfer is likely to fail for several reasons. Maybe the patient is old, even though Jean Cany has proven that older patients do well with the tendon transfer. If they have a high BMI, we know that they're not going to be very successful with a tendon transfer. If they are heavy smokers, if they are manual workers and they need lots of strength, well, maybe this could be an indication for a reverse shoulder arthroplasty, although the shoulder is not pseudoparalytic. So it's just for pain and the gain of function, of course, but for pain mainly. Then you have the non-functional shoulder. There it's easier to decide. So again, when you have no rotator cuff, the vertical plane is the vertical couple, is ruptured, and so you have translation. So these cases, you have elevation lag sign, and so we've seen videos of these cases. There's no doubt these are pseudoparalytic cases. When it is chronic, I don't know of any transfer that can reverse this pseudoparalysis, and so for me, it is the way to go with a reverse shoulder arthroplasty and to have satisfactory results. Then you have isolated loss of external rotation. You see his elevation at this guy is perfect, but abduction is fine, but he has an external rotation lag sign. He has no posterior cuff, so no supra, no infra, and no teres minor. Well, for these patients, there are two options that have been described with successful results in the literature, either the lower trapezius or the latissimus dorsi, but you notice that I didn't take the same picture as before for the latissimus dorsi because I believe you should not position the latissimus dorsi similarly when the goal is just to gain external rotation. You should place it like a lepiscopo transfer like we do with a combination with the reverse. For the loss of active internal rotation, and this is a patient from Bassem, and you can see that this patient has absolutely no subscap. He has an internal rotation lag sign, and this is what Thibaut demonstrated before. We have two tendon transfers that have been described, the pec major and the latissimus dorsi, although these two tendon transfers are not very good at restoring active internal rotation. They improve internal rotation. Then there is the combination of both, either a posterior superior escape or an anterior superior escape, so a combination of the loss of elevation and internal rotation, or the loss of elevation and external rotation. And for these patients, to treat the vertical balance, I don't think that you have any other solution than the reverse shoulder arthroplasty. And then you need to treat this internal rotation balance. And so you can combine this with tendon transfer for external rotation, although this is again debated because now it seems that with the posterior deltoid, you can maybe recover some active external rotation, even though I think if you have preoperatively a negative external rotation, the reverse shoulder arthroplasty alone will not be enough. And then for internal rotation, we have a biomechanical study showing that the pec major could lead to an improved internal rotation. I know Philippe Valenti is about to publish a series of that, but I don't have any experience myself. But at least for these patients, reverse shoulder arthroplasty is the way to go. So when is reverse shoulder arthroplasty the way to go for irreparable rotator cuff tear? Well, in the non-functional shoulder, there is no doubt. It's a green light, not limited by pain. Elevation lag sign, the only solution is reverse shoulder arthroplasty. Then when you have a painful loss of active elevation, these patients, they have a functional shoulder. It is a theoretical indication for tendon transfer, but in some cases, these tendon transfers are likely to fail, so maybe we could go directly to the reverse shoulder arthroplasty in these patients. You have to keep in mind something that is important, is that in this population that has a preoperative elevation superior to 90 degrees or high preoperative ASCS scores or high preoperative SST scores, these patients have been proven to do not as well with the reverse shoulder arthroplasty that the patients who do really bad preoperatively. Thanks a lot for your attention.